introduce is Dr. Lauren Doyle Strauss. Dr. Strauss is a child neurologist in Winston-Salem, North Carolina, and is affiliated with Brenner Children's Hospital and Wake Forest Baptist Medical Center. She received her medical degree from New York College of Osteopathic Medicine, trained in child neurology at Boston Children's Hospital and headache medicine at Brigham and Women's Hospital. Dr. Strauss's work as a pediatric neurologist centers on improving the lives of children with headache disorders through educating patients, parents, and other headache healthcare professionals. She is a leader in educational initiatives, including the Migraine Action Plan published in Headache Journal, and is the residency director for Wake Forest School of Medicine's Child Neurology Residency Program. She has been recognized as Best Doctor in America since 2017. She serves as a Southern Headache Society Board as Communications Director. So welcome, Dr. Strauss.
Hi, everyone. Thank you for that warm welcome. I'm going to switch over and share my slide screen, so give me a moment. Okay, does it look okay?
Looks great.
Yep. Wonderful. All right. Well, thank you for inviting our program to speak today. And we really enjoyed participating in the Miles for Migraine Walk in October, which was at Salem Lake. And it's just, you guys have such a wonderful organization, and to now know about your support groups and then also participate today in an educational day, it's really wonderful for our patients in our community, and now this is reaching, our community is reaching maybe some patients outside of our community, but it's just patient-centric, and I think it's so important. So I would love to talk today about, everyone has a different migraine experience, but I think it's very important to work with your provider who's caring for you so that you have a migraine action plan and that you are prepared for your migraine attacks. I don't have any disclosures or influences to disclose for the content of my talk. So I get this question a lot. I'm a pediatric headache specialist. Of course, I see some adults too, but a lot of people in the community don't realize, and some parents of their own children wonder, how common is headache in children? And it's actually a very common manifestation of pain. It's actually the most common manifestation of pain is in the head. And we have some statistics to show that children upwards of a third can have recurrent headaches, and 2 to 6% of children can go on to have a daily headache. So unfortunately, it's not only adults that can have chronic migraine, it is something that we battle in children too. And because of this, this ends up being one of the most frequent reasons that children and their families will seek out neurology referral or emergency department visits. And we have some literature looking at what happens when children reach the emergency room setting for severe headache attacks. And we notice that families are waiting a long time to reach the emergency room. Sometimes headaches have been lasting 2 to 3 days. And about a third of patients may not have even tried a medicine before they seek out the emergency room. And when they come in, when you look at if they have taken a medicine, what have they taken? Most have only taken over-the-counter medicines, and triptans, which we'll review later, are an awesome class of medicines. They're specifically designed for migraine. Only about 2% of children had tried that triptan. And certainly, some of these patients are new to having their first headache or new to having recurrent headaches, but that's certainly, it just really highlights that there's a need to serve here in educating patients, families, and also primary care doctors that we can do better. And opioids, which, there are some patients that's, there's a role for those, but in general, we do try to avoid using them because they can sometimes worsen migraines. And if you look at the striking, how the statistic that more children have been offered a narcotic than a triptan, that's surprising. And so entering into this specialty and wanting to care for my patients, I just it really impressed upon me that children are often untreated or undertreated. And that's where I wanted to focus this talk on ways we can help there. So it's really important to be prepared, right? I'm a planner, and I'm trying to encourage patients and families to be planners too. Have you made your own action plan? So it's important for this talk to just review some terms, and these are ones that we use as doctors, and sometimes we'll use them in our visits. And so just want to make sure we're all using the same language, in that we use the word acute and sometimes abortive for a medication that's first line that you're going to use at the sign of a first attack. And then when a headache is persisting and not responding to your acute medicines, then we refer to that next level as a rescue medicine. And certainly all of these medicines, acute and rescue, are trying to rescue you out of your pain, but we try to use those terms for different stages of use. And then a daily preventative medicine certainly has its role where you're trying to prevent the need for acute or rescue medicines. And that's something that you take every day to prevent or reduce pain and make them more responsive to medicines when you take them. There are a lot of options, and I really want to stress that a lot of the options that I feel very comfortable using in an adult, I will use in children. It doesn't mean that I'll start with some of our more heavy-duty medicines, but all of these options are usually on the table, and I just want people to have hope that there are a lot of thoughts, different things to try, and I want to try to break them up into different classes. But we certainly have our analgesics. These are our NSAIDs, things like ibuprofen, naproxen, ketorolac, and then we also have a class of antiemetics, which is our term for anti-nausea medicines. And interesting about this class of anti-nausea medicines, I have to coach patients that it's not only for when you have nausea. These medicines can be used for patients who don't even experience nausea and vomiting during a headache. They can be used to take out pain as well. And then we'll review some combination medicines that are out there that are over the counter, and some that are prescription. Triptans I've already briefly mentioned. There is a role for some antihistamines. Not that you need to have an allergy as the clear trigger of your headaches, but this class of medicine can help. And certainly our younger children, we find that cyproheptadine is an often go-to medication that can be helpful with minimal side effect. Okay, and I've added in, it was kind of exciting to add a new potential class for people to try, which is the GPANs. So there's just a lot of new things that are coming out, and super exciting time for providers to be able to offer these treatments for our patients. So I put this slide together, not that I want you to race down and write down what's on the slide, but this is just to impact on people that when we talk about triptans, there are 7 options. And I have a lot of patients who come in and say, I already failed triptan, and they've only tried one. And we like to coach patients that, it's like looking for a good pair of shoes, right? You got to keep trying them and find a comfortable pair and one that you think is cute, right? So every different triptan, someone can have completely different experience. You can find one that is completely effective, no side effect, and then another one was horrible with side effect and didn't touch your headache. So we will cycle through at least seven of them to say that you have failed them. Certainly, if you have a pretty bothersome side effect and you're hesitant to try more, we understand that, but I just want everyone to know that there are a lot of different options. And we also divide them up into fast-acting and slower-acting triptans. And there's different strategies on when we choose the fast-acting versus the slow-acting. I may go to the slow-acting if you've had a negative experience with a fast-acting triptan because it has a slower onset, so it may not have as much side effect associated with it. I also may use slow-acting triptans around people's periods to try to use it as a spot prevention. So you may not have your pain yet, but every time of your month, this is a risky time. Maybe I'll use a triptan just one time a day for 3 days to try to prevent pain from coming on. And the other thing to impress upon you is that there's different dosing for each triptan, and they're not comparable. So a sumatriptan dose of 50 is not more than a rizatriptan dose of 5 milligrams. They're just independent dosing, so you can't really compare them. Often you'll see providers will start with the lowest dose first, and especially in a child, we start with the lowest dose first. And then depending on your experience, we will go to the higher dose. And there's a lot of different ways to administer triptans. So oral is not a tablet is not the only option. There are meltaways, nasal sprays, and okay, with triptans, It's important to know that I already brought up try again, but there's the rule of twos. And so if you try a triptan and you're not finding the success that you're hoping to have, you can repeat again in 2 hours. You're supposed to limit to 2 treatments a day of that triptan, and then 2 treatment days per week. So if you use it 2 days a week and 2 pills within that day, 2 times 2, you will do 4. So that's not necessarily the rule of twos, but you understand what I'm getting at is just we're trying to limit it, but we also want to encourage you to redose if you need to. And if you have more than one triptan in your medicine cabinet, we don't want you mixing them within one day. They do have action on the same area of different receptors, and we wouldn't want to increase your likelihood of having a serious side effect. So if you pick a triptan to use, that's the one you're using for the day. And there are certain side effects that can come with triptans, and they could be bizarre for some people who've never experienced it, where there's some action on blood vessels where patients can experience a tightening. And so sometimes patients sense that, and they will feel a tightness in their chest, their throat, or in their face. And so it's important for hopefully that your doctor is going to tell you and share that with you so that you don't think that you're having a severe allergic reaction or anaphylaxis. So that can be common, and it doesn't always persist with future doses. So it's something to do, and it could cause flu-like symptoms, feeling flushed, hot, bothered, muscle aches, cramping, feeling dizzy and tired. Most commonly, a lot of our patients don't have any side effect, and I do find that my children, although there's a lot of caution in using prescriptions for children, I find that our children tolerate these medicines much better than our adults. And in our pediatric headache specialty community, we often talk about we even feel more comfortable escalating to higher doses, and maybe the children metabolize the medicine faster. So it's a great class for all ages to consider. And certainly there are some cautions we have to have with this class. And if you have high blood pressures that are not well controlled, we would be very careful in giving you this medicine. So combination medicines, and there are just a lot of options here. So I think it's important to caution that although caffeine can be very helpful during a headache, and it even can have its own analgesic effects and amplify the effects of other medicines. That's why a lot of companies are throwing them into combination meds. If you are going on to have a refractory headache pattern, chronic migraine, we very much worry about adding caffeine into that mix, because caffeine, it can, either by drinking it and having part of your diet or in a medicine, we worry that it could actually lead you to have more headaches and lead you to have medication overuse headaches. So there's a role for caffeine in acute medicines, but you need to be careful. So on the left side are the over-the-counter options, and on the right side are the prescription options. And I think it's also important to highlight, a lot of people don't realize that not only do they have caffeine in them, and sometimes from pretty high doses, it's like 1 to 2 cups of coffee worth, but they also have really high doses of aspirin. So if you're an adult and you're already on a baby aspirin, this is something you want to be really mindful of taking something like this, and certainly you wouldn't want to take more than one. So that's a concern. And in children less than age 15, we do worry about a serious phenomenon called Ray's syndrome, where if you happen to have a flu-like illness and then you're exposing your child or giving your child an aspirin-containing product, you can have an acute onset liver failure. And it's a really serious condition. We don't see it often anymore because a lot of the bottles have this warning on it. But just be careful about these doses. Imagine giving 520 milligrams of aspirin to a young child. So there's a caution there. But these can work. You just want to be careful about how you use them and limit them to a sparing use. Okay. So I think it's also important to identify your own needs and your preferences, and share that with your provider. We can't always read your mind. We try to ask a lot of questions and dive in a little deeper, but if we prescribe something and you're worried and you think, the insurance didn't cover it and this is a barrier for me, reach out and let us know. Sometimes it's just a simple prior auth wasn't filed, and we can overcome that. If you as an adult, or you're worried your child cannot swallow pills and we prescribe a pill, please let us know. There's so many different options out there that we can do. If you have a lot of nausea and vomiting and you're just saying, I just can't imagine swallowing something during this, or I worry that when I swallow it, I just don't think it's getting digested, please let us know, because we can switch. And if you're getting to the point where we're thinking about rescue meds and we're prescribing needle injections and you're like, you know, I'm needle phobic and I know I'm never going to give this at home, it's just not a possibility, that's important. And please let us know so we can reroute and think about other things. And I like to think, you know, it's yes, the point of our acute medicines are to reduce pain, take the pain away, and some of our associated features like nausea, light, and sound sensitivity. But you know, the biggest goal is so we can reduce your disability. And if we can't take away all of those symptoms, we want you going back to what you were hoping to do, whether that's caring for your children, working, going right back into the classroom. And if you have concerns about side effects, or you just have a scenario that you are worried, I cannot be dizzy, I cannot be sedated, these type of situations are things that you want to let the doctor know. So I put together this slide from an article that I did in Practical Neurology of different non-oral, so non-tablet options for people. I just wanted to show you there's just so many things available. There's some liquid formats for younger children. There's a powder and diclofenac that could be a little bit faster acting because it's been broken down and you add it to liquid. Some chewable and dissolvables, two triptans, the rizatriptan, zolmitriptan. We have a few nasal sprays. And injectables. And then, you know, we do have some patients, there's a role for rectals at times. And then topical, I mentioned that, you know, prochlorperazine or, you know, some of our antiemetics, you can work with your provider to work with an apothecary and have a tablet broken down into a gel and a syringe. And then you can squirt a small amount on your wrist. And that's another way to get some of our tablets in as a workaround. Okay, and I put together this slide to look at which ones actually do have FDA approval in children. I get this question a lot. Now, to be very clear, I'm pretty much using almost all medicines, and I don't always start with the ones that are FDA approved, but for families that are very cautious and worried and want to start with only FDA approved medicines, that's certainly reasonable. So your triptan options are going to be rizatriptan, alomotriptan, and zolmitriptan. Oh, okay, I didn't realize I have animation here. Okay, so acute headache treatment. So as we pull it together, I like to think of different stages. And you may have the most severe attacks, and we know we have to go right to stage 4, where it's like we're hitting it with everything. But it really just depends on the severity and the frequency and what your personal situation is and how disabled you are from your attacks. But as prescribers, we'll often think, you know, can we start in stage 1, where we give a simple analgesic, you know, something over the counter, maybe a prescription NSAID, things, you know, in that level. But certainly, if it's more significant, then we think of stage 2, where maybe we need to give a stronger prescription or other types of classes of medicines that are the anti-nausea, antiemetic, or even in the antihistamine category of hydroxyzine, cyproheptadine, and that maybe they can be paired with an analgesic. And then stage 3, which are these headache-specific medications, when they work, they can work really well and take down a headache, we hope, very quickly. And these would be the triptans that I mentioned, and now the new class, the GPANs that are just coming out. And, you know, sometimes we do need to rely on dual therapy or all 3 together, or depending on your symptoms, we may start with an anti-nausea medicine, anti-nausea medicine first before we try one of the other oral medicines. It's important, no matter which medicine you're choosing, that you treat early. We do know the first phase of the headache. If you get a warning of a prodrome, or you get a warning of a neurologic symptom, like we call an aura, if you're getting a warning that you know that headache is about to come, that's the time to reach for your medicines and try to treat as early as possible, because we know that you're more likely to get relief from the medicines you're choosing. If you have a really strong headache, I'm sorry?
I had to dial in for the audio part. No, it's okay. They're still doing children's stuff.
Please mute.
Yeah, we can hear you. So go ahead and mute yourself, the person who just joined. So treat early. And she did make a comment that this is only children's stuff, but actually this applies to all ages. So these kind of treatment protocols. So treat early, definitely in the first phase. And certainly be aware of medication overuse. We want to limit it to about 2 days a week. And if you're having headaches that last a long time, then there's a need to treat with the strongest medicine first, not to reserve the strongest medicine for later. You want to treat that in the beginning. And some special advice, if you're very concerned or cautious about trying a new prescription, you don't have to take it when you have a headache. You can try taking it when you don't have a headache. And that way you can be in control. You pick a time when you don't have something else planned so you can see what those side effects are. So these are important questions to discuss with your provider. You know, when you're using acute medicines, when do I use the medicines? How do I choose which medicine? Can I take them safely in combination? Is that what you're recommending for me? And how long is too long? Like, how long is it going to be until I find help, and give me some advice there? And what kind of side effects should I expect? And what are your strategies for me, or doses per week? Usually it's going to be limited to 2 days a week, but there are some interesting classes of medicines where we don't have to worry as much about medication overuse headache. And then the next stage was like talking about rescue medicines. You know, when do I use one of these rescue meds? Is it after 3 days of using acute medicines? When do I bring those in? When do I go to seek more urgent care or emergency room setting? And can I take my rescue meds more frequently than just once a month? You know, what's the frequency there that we feel safe using those? And then as the patient and family, I think it's important to create a list of each medicine and document your perceived helpfulness and side effects, because it may end up being a long road for you. And looking back, you can reflect, because sometimes we retrial old medicines again. Okay. So when we talk about planning, sometimes people want to think about creating a migraine space. I put a cave just because some of my patients will call it their cave, you know, if they're very light sensitive. But this doesn't have to be a cave. It could be a safe space at home, at school, at your work, and your possible needs that you might want to plan for. You need to have a sign to keep it private. Do you want to have your earplugs, headphones, a blanket to put over your head to keep out the lights, blackout curtains, things like that, a hat, glasses. And then aromatherapy, we have patients who have a diffuser in their space where they'll diffuse lavender or peppermint, or maybe they want to apply topical peppermint. So that's something to think about, hot or cool packs. I have one patient she's very blessed. She has a refrigerator in her migraine space, and she keeps her cold packs in there, and her Gatorade or electrolyte containing fluid, and she's all ready to go. So I think that's something to think about. And then now we have neuromodulation devices. So your Cephali and some of the newer ones that are just coming out that are smartphone accessible. You know, do you want to have those available, and where are they? Easy access, of course, to the bathroom if you can't make it to the bathroom. You know, other things just in case you were to vomit. All right, so I wanted to pull up, so I've been involved in several national initiatives, and these are geared to educate providers, but certainly these are things for you to think of. Do you want to have a conversation with your prescribing provider about your action plan? And the first one I'm showing is pediatric specific. This is the Pediatric Migraine Action Plan, or PED-MAP. It's kind of inspired by the seizure action plan that's very well used in schools. And what this does is this is a communication tool with not only the patient and their family, but also the school, so that we can get quick access to medicines for our children, and then hopefully reduce stigma. So this is an option that you can access online. I think it's published in the Headache Journal. And this is something you could bring to an appointment to have your doctor sign and kind of use that in your school district. A lot of school districts in our region are very supportive. They already have their versions of these, but this is helpful for some school districts that don't. So then we move on to the migraine action plan, and this can be used for all ages. So that would be kids and adults. And this is a design to kind of be like a choose your own adventure. You work out with your provider, what are my acute medicines in my step 1 and my step 2, as maybe my rescue, kind of being very clear what the diagnosis is and what your usual symptoms are. And the goal with this is not only you keep this at home, but if you end up in the emergency room, this is something you could share with those treating providers. And the page 2 of this form looks at when should you seek out care to the emergency room. And then if you hit the emergency room or the urgent care, it would be nice if the doctor or APP who knows you best could pick out what those medicines would look like. A lot of our headache patients are really disappointed when they have to wait a long time in the emergency room, and they feel that no one really understands, and they're giving meds that don't always help them, and they've tried in the past. This is a way to kind of get there faster if your treating provider's already picked out those meds, so you can get boom, 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 because we know treating earlier is better. So that would be helpful to have. When do I seek out that care? and what are those meds going to look like. Oh, and one thing I'd like to bring up is that if you find success in the emergency room, or if you have a serious side effect, I think it's important to ask while you're there, what did you give me? You know, because we can't always see those records. And, you know, if we found something really helpful, like we want to make sure that we use that the next time in the very beginning. And if you had a serious side effect, we want to make sure we can avoid that the next time. And as you have new medicines, I think it's always important to have a headache diary and track when you're using your acute and rescue medicines. And the point of the diary is to help you so that you can communicate with your provider. And we find it helpful for you to track your headache intensity, maybe if you have menses or periods and when the bleeding days are, and then changing of some daily medicines. But the hope is that you come prepared so we can look, and I might discover you're underutilizing your acute medicines or that you're overusing them, right? And so I think it really helps to track that so you have that conversation. So I hope from this talk that you gathered how to be prepared for your next migraine. You know, we want to encourage you to have that conversation with your treating provider, because it's not just which medicines, but how I use the medicines and when to use the medicines and what the strategy is there. And we want you to be familiar with what your medication options are, and when and where you should seek out other care.